Okay, so today's presentation is on scanning the knee ultrasound, and I'm going to talk about just normal pseudoanatomy and some important points that you need to keep in mind when you're scanning the knee. This is the basic level, so people who have just started doing it, or maybe you have done a couple of them, you may find these points, these important points, useful when you're scanning your patients with knee problem. Okay, so these are the 6 important points that you have to keep in mind when you are scanning the knee joint or knee area. First is patient positioning. Patient positioning is important. Because if you do not have proper position, there are some structures which do not appear clear or may show hypoechogenicity, which can be confused with pathology when they are normal. So it's easy to see pathology if you don't put the knee in correct position or don't place the patient in the correct position, and that's because the tendon is at the slack. So whenever you're scanning a tendon around the knee, make sure that the tendon does not have a slack, so you so to stretch it out a little bit. You don't have to stretch it a whole lot, not like proper stretching, because if you stretch it too much, then you are also obliterating the any defects the tendon may have. So take out the slack for knee, quadriceps, and patellar tendon. Make sure the knee is in 30 degrees or more than 30 degrees if you still see the slack in the tendon, and I have some images where I will show you adding more flexion makes a big difference. Then the third point is the structure of interest. So if you are doing a specific study where a patient has only posterolateral or posteromedial pain, or even if you're doing a comprehensive scan, but there is an area which is the primary focus of the study, make sure you take additional images of that, and take images both in 2 planes, long axis and short axis. And the principle of taking images in 2 plane is applicable in every in every case in ultrasound. For every structure, you have to take images in 2 planes to confirm your findings, whether normal or abnormal. And make sure you're always using the color ultrasound button on your machine. You want to see the vasculature. That color Doppler button can be used to see if there is any vessels around, and also to see any inflammation. So if you have a case where there is synovitis or tenosynovitis, there is a thickened synovium with the vasculature inside it, and you can see that vascularity on the color Doppler. Then depth, I cannot emphasize this enough. That's the most common whenever somebody starts scanning or using the ultrasound. That's the most common mistake, that they don't use enough depth, or maybe they're too shallow or too deep. You have to use the correct depth for shallow structures. Don't use too much depth because you don't get good resolution of the structure. If you are looking for something deep, then make sure you're not too shallow. You don't want to get the structure of interest at the bottom of the image. So appropriate depth selection is very important. Okay, now patient positioning and limb positioning. Let's look at that. So the first one I have here is quadriceps tendon, which is the most common tendon that you image, and patellar tendon too. And it's important to have knee in 30 degree of flexion, and to see the bony landmarks patella and femur. And the next image will help you understand why it's important to see bony landmarks. So on the left, there is an image of quadriceps tendon attaching to patella. On the right, that bony margins that you see is patella, and that's the tendon. And proximal to is femur, and the black or hypoechoic signal that you see overlying the femur is the articular cartilage. So here you're looking at tendon as well as both the bony landmarks, patella and femur. And if you have This image, this is a good image where you get to see tendon, bone, and joint recess. If there is any inflammation, you will not miss that. Now let's look at the image on the right. This is from the same patient, same knee, but the depth, if you notice, on the left is 2.7, on the right is 2.2. Now look, if you are using less depth and also you don't have the tendon a knee bent 30 degrees or more than 30 degrees, look at the slack in the tendon. And here you see focal hypoechoic area, which can be confused with pathology like tendinosis or tendon tear. So this tendon on the right looks abnormal. On the left, it looks normal, although this is from the same individual. And so positioning makes a big difference, and that's especially true for tendons and as well as ligaments. Now the second one is when you do sunrise view of suprapatellar region, patient is supine and you ask the patient to do full knee flexion. And the reason for doing full knee flexion is because when the knee flexes, the patella moves distally, and you get this window where you can see the trochlear groove or the area where there are articular cartilages, and you put the probe transversely across this area here, and that gives us access to the cartilage and the joint area. So it's important to scan the this area and move like from proximal to distal to get the optimal and the good view of trochlear femoral trochlear cartilage. Because look at this example here. Again, on the left you see the femoral trochlea and the articular cartilage uniformly lining the distal end of femur or the trochlear area, and so this is a normal looking trochlear cartilage. On the right you see there is some cartilage here but looks non-uniform, and again you don't see any cartilage here. And this is again from the same patient, same knee. Look at the depth is correct. Depth is same, is 2.2 centimeters for both the images. The only difference is here in this view you're slightly proximal to the cartilage area. So rather than where the red line is, you're slightly proximal to it. So you're not getting the whole view of the cartilage. So look on the right side, you don't have cartilage here, so you're missing this part of the cartilage. And that's the reason for this view here, although this knee is normal. But if you look at this image and you're not the one who's scanning the knee, you will say this is an abnormal trochlear cartilage. Okay, now the next one, moving on to patellar tendon. Again, you have the knee in 30 degree of flexion, patient supine, and the bony landmark here is patella, femur, and tibia. And the reason why I have written sometimes is because sometimes in some patients you may see the tendon is very long, so you may have to divide your long axis view in two parts. One where you see the patellar attachment of the patellar tendon and where you see the tibial attachment. But bony landmarks are very important. So let's move on to see this one here. Okay, so here again I have the image comparing. On the left you have patellar tendon attaching to patella, distally attaching to tibial tuberosity, and on the right this is not optimal. You don't have enough flexion to stretch out the tendon. So look at the distal end of the tendon. It looks thickened and hypoechoic, and it looks non-uniform. It doesn't have the uniform thickness, and it looks abnormal. Again, the reason being because we did not take the slack out of the tendon, and that's why you get hypoechoic abnormal signal there. And that's an artifact, not the true pathology. Okay, now in lateral collateral ligament scan, you do it in side lying. Patient is side lying. Knee is not more than 30 degree bend, because if you add more than 30 degree, then your LCL becomes lax, and again you will see hypoechogenicity, which can be confused with pathology when there is not. Then it's important to see the bony landmarks, because in this area you have three structures very close together. You have biceps femoris, as you can see in this image. Biceps femoris is cut, but you can see it's right overlying the ligament. So you have biceps femoris, you have LCL, and you have popliteal tendon crossing obliquely underneath the LCL. And one thing that they're not showing here is your, oh yeah, they are showing here. IT band also crosses over this area to come to the Gerdy's tubercle. So Gerdy's tubercle is right here in on the anterior aspect. So it's important to see these three landmarks. If you have tibia, femur, and fibula, you know you're over the LCL region. And here is the image. So on the left, you see the LCL, and it's normal to see LCL in more than one, to see the complete LCL in more than one view, because again it's not always completely straight. So you may get one end of the ligament which looks fibrillar, but you may not be able to get the whole span of the ligament in just one sweep. So it may take two long axis views to see the whole span of the ligament. On the right, you will see there's a slack in the tendon, oh sorry, ligament, LCL. So on the right side of the image, you have LCL, which appears hypoechoic, and especially where it's attaching to fibula. But you will also notice that there's a little slack in the ligament, and that's why it appears hypoechoic here. So for tendon and LCL, and now this is an image where you cannot tell what is what, because we did not position the limb correctly to differentiate LCL from other structures that are crossing this region. So this is a difficult image to analyze LCL. And on the right side, you see an anatomy image of LCL and the lateral aspect of the knee, showing that there are so many structures that are crossing this area, and they are more or less in the same alignment. They're longitudinal, running long, and so that's why proper positioning and bony landmarks are very important. Okay, lateral meniscus. Now you do lateral meniscus scan, and again patient is side lying, knee is extended, and you put bolus or a pillow between the legs to add a slight varus stretch, so you get some access to the lateral area of the knee. And the probe is positioned slightly oblique. It is lateral and slightly oblique, and that's because of the anatomy in this region. To get a better access, you don't want to be you don't want your probe to be straight long axis or exactly longitudinal to the long axis of the leg. You want slightly posterior lateral orientation of your probe. And bony landmarks are your tibia and femur, which is the joint. And here is the image. On the left, you can see on the left of the screen, this is femur. On the right, that's tibia, and you can see the lateral meniscus as a triangular structure here. On the right side, because the probe was not angled here, so in this, on the right side of the image, the probe was kept exactly long axis to the long axis of the leg or long axis of tibia, and without probe angulation, you don't see the lateral meniscus properly. So make sure when you're on the lateral aspect of the knee for lateral meniscus scanning, slight oblique orientation of the probe, posterior lateral oblique. Okay, the next one is peroneal nerve in on the lateral aspect. Bony landmark is fibula because it wraps around the fibular neck. So you go behind or on the posterior aspect of fibula and you scan the nerve. It is best scanned in short axis view. Most of the nerves are easy to follow when you're scanning them in short axis view. You could follow them proximally. So if you start distally, you can follow it proximal where it connects to the sciatic nerve, or you can do the reverse. You can start scanning from the popliteal region, find the sciatic nerve, and then start scanning laterally to find the peroneal nerve. Now this is an example, or sorry, the image of peroneal nerve. So the hyperechoic bright structure that you see here is your peroneal nerve, and that's fibula, the bone that you see here. That's the fascia. That's the lateral compartment fascia. And peroneal nerve, if you have scanned knee and you have looked at peroneal nerve, it looks flattened and hyperechoic because it travels between fascial planes. And whenever nerve is traveling between fascial planes, it's more flattened compared to when if you see them in any tunnels where they are more hyperechoic and you can see oval or round appearance. So here, because there is hypoechoic muscle around it, you will see the nerve appears more hyperechoic or bright or white. Okay, looks like we have more people joining. Okay, all right, let's move on. Now let's go to the medial aspect. So on the medial aspect, we scan MCL, medial collateral ligament. In this patient is supine, limb is externally rotated to get the access of the medial aspect of the knee, and the bony landmarks are tibia and femur. And if you look at the ligament, it's a really long ligament. You know, before you don't appreciate how long MCL is before you start, like, unless you start doing ultrasound and you start scanning the whole length of MCL, it's really long, and it goes all the way from adductor tubercle to the anteromedial aspect of the tibia, where pes tendons attach. So that make sure when you do MCL scanning, especially if you're suspecting a strain, sprain, partial tear, or any valgus stress, sorry, if there was an injury with some valgus mechanism, make sure you scan the whole length of the MCL, because it may be partially torn and the fibers may be retracted up to the very proximal part of the fibers around adductor tubercle, or maybe on the anteromedial aspect close to the pes tendons. So the fibers can be retracted all the way proximal or distal. So it's important to scan the whole length of the tendon. And here is the example. On the top image, oops, sorry. On the top image, you will see the MCL. On the left, you have femur. On the right, you have tibia, and you can see the medial meniscus here, and hyperechoic MCL. You can see it's spanning. It's on the knee joint, at the level of the knee joint, and on the left, I have image of the ligament fibers wrapping around the femur and going towards the adductor tubercle, and that's where the proximal attachment of MCL fibers is. And on the right side of the screen, I have the distal aspect of the MCL. So to scan the whole length of MCL, you actually need 3 images: one in the middle, one proximal end, and one on the distal end. Actually, for the distal, I can even go a little bit more further. So if I go slightly more, I will see the insertion of MCL very thinning out, and it's attaching to the bone. It gets thin as it's attaching to the bone. So that's MCL. And here, just giving you an overview that there are other structures that you can assess when you're scanning MCL. So you start scanning MCL at the level of knee joint, then you go proximal to look at the fibers attaching to adductor tubercle, and then you go distally and see the MCL attaching to anterior medial tibia. And right at the insertion of MCL, you will see pes tendons crossing obliquely over it. And if there is any pes bursitis, you will see the bursal effusion or hypoechoic or anechoic signal right at the distal end of MCL. So you can assess pes in the same view with MCL. Okay, medial meniscus. You can get medial meniscus from the same view of MCL. Again, patient is supine, limb is externally rotated, and bony landmarks are tibia and femur. The same image where you can see ligament, MCL, and the meniscus. Now, in the bottom left and right image, I'm just showing a slight change in my probe placement. So on the left side, I'm slightly posterior. I'm sorry, I'm slightly anterior, and on the right, I'm more posterior. So you can see you have to find where you get the best view. So in the middle image, the top image is where I see the meniscus better compared to the left and right, and that's because of the anatomy of this region. If you're too anterior or too posterior, the meniscus may look abnormal, so you have to stay somewhere right in the middle to see the meniscus properly or clearly. Let me get back to that image to explain it better. Here. So you see this area right in the right on the medial aspect where you get the MCL ligament. That's where you get the better access of or better view of medial meniscus. If you are more anterior or posterior, it may appear more protruded in the anterior view, and posterior it may look you may not get enough or good access of the medial meniscus. So in the same view where you see MCL, you can see the medial meniscus well. And every patient is different. Right now we're talking about normal scans, expecting a normal anatomy, trying to get the probe placement correct, patient position, and to understand how normal structure look like. Abnormal can sometimes throw you off, and sometimes you may have to change the position and limb position, probe position to see the structures better. Okay, popliteal fossa. Here patient is prone, knee is extended, and you are expecting to see nerve, vein, artery in a stack formation, and you may also see bony landmark on the deep side, which is femur. And it's very important to see the bone because if you have a cyst or Baker cyst or semimembranosus gastrocnemius bursa, you want to see the root neck of it. And if you don't have enough access, so let's say if you are not 4 centimeter like in this image on the left, and you're somewhere in the middle here, you're only seeing the bulk of gastrocnemius, medial gastrocnemius, you're not sure if that's a ganglion cyst or that's a Baker cyst, because not every cyst in the popliteal region is Baker cyst. So it's important to see the stalk of it or neck of it going towards the joint. So here on the left, I have the image of popliteal fossa. I have some femur here. These are blood vessels. So I have nerve, artery, and vein. Which one is what? I can find that out by putting little pressure. You can close the vein, so you can put pressure and you will squish the vein, but you won't be able to squish the artery because it has muscular walls and it pulsates. The second thing that you can do is turn the color on and see which one is lighting. The one which is not lighting up is vein, but it could be a cyst. So what's your next step? So step number 1, compressibility test. You put pressure with the probe, see which one you can squish, which one you cannot. Then step number 2, you turn the color on and see which one is lighting and pulsing. You know the artery and vein. The vein and popliteal region can be really big. They may look like a big cystic mass in short axis view. Here this is not too big, but so we think this is vein, but we're not sure. Now what you do after that, you will trace it proximal and distal. If it's a vein, it will stay the same caliber, proximal to distal, and then you will move long axis on it, and it should appear like a tubular structure and not a round mass in the second view. So let's look at the long axis. So in the long axis, I see a tubular structure, but it's still not uniform. Here the dimension is bigger compared to the proximal side. Now I turn the color on and I see the vascularity, so I know this is vein. But if you don't turn the color Doppler on, and you cannot compress it because there can be sclerosis in these veins, and you may not be able to compress them. If there's a plaque and or thickening of the wall and there's partial flow, you may not be able to compress it. So you need to turn the color Doppler on. If you don't do that, we're not sure if this is an effusion coming out from the joint or if this is a vein. So the best time to test all this is when you are actually with the patient and you have the ultrasound, you have the option of using the color Doppler, option of putting some pressure with the probe to obliterate these vessels, or go short and long, a little bit more proximal and distal to this structure. Let's look at the second one. Here, the vein appears, suddenly there is increase in the caliber of the vein. And veins can give you appearance of, like, they can be tortuous. The lumen can change in dimension. There is dilatation somewhere, and they can have bulbous appearance, especially in lower extremity. Even around the ankle and leg area, they may have a tortuous or bulbous appearance. Most of the time you will be able to differentiate easily by going short and long on it, by turning the color on, or by putting some pressure. If not, use a color, and make sure you do these three things: probe pressure, going short and long axis on them, turning the color on. It's important. So if you are suspecting a patient with the Baker cyst or a patient with the posterior knee pain, and they feel tightness or stiffness there, and you're suspecting a Baker cyst, which is essentially effusion of semimembranosus gastrocnemius bursa. So this is a left knee, that's medial femoral condyle. This is medial gastrocnemius, and that's the tendon of semimembranosus, the one with the star, and the blue that they're showing is the sac or the bursa between these two tendons. So here the big one that you see is medial gastrocnemius, and just medial to it is semimembranosus bursa, tendon, and this is the area from where you should see the neck coming out. That's when you know this is Baker cyst. Here, looking at the image with greater depth, here you have medial femoral condyle, you have medial gastrocnemius, and that's the tendon of semimembranosus. This is where the stalk or the neck of the cyst should come out. So it should be like a neck or stalk, and then a cystic mass, a rounded cystic mass here. So that's when we call it Baker cyst. Otherwise, if you're not sure, then we don't call it Baker cyst. We just say it's a cystic mass in the posterior aspect of the knee. But it's very important to find out the source, where it's arising from. Is it arising from the joint or around the tendons? It's important to tell the nature of the cyst. And we covered all the aspects of the knee and all the important structures and important points that we have to keep in mind. If you have any questions, I can answer them now. If you have any questions on the knee, or if you have any patient specific that you have in mind, and so this is an open platform right now for any questions. Questions? Okay, I see one question. So first question is, what would the protocol be for a drop foot suspected from knee? Okay, good question. So if you have a patient and you are doing, so I would say if I had this patient, I would do EMG, and ultrasound both for this patient, because the drop foot could be from stenosis, peroneal neuropathy, sciatic neuropathy, uh, peroneal neuropathy at the fibular head. First, do the EMG, and then follow that up with the with ultrasound of peroneal nerve around the fibular head. So if what you would see is, although it's not very common to have peroneal neuropathy at the fibular head unless patient was bedridden and there is sudden loss of weight. It's not a common entrapment to have. But what you would do is you'll scan the peroneal nerve at the level of fibular head, and also going a little bit more proximal around the knee joint, because most of the time if prolonged bed rest or sudden weight drop is not the reason, the second common reason is there's a space occupying lesion. So you will see a mass, maybe a ganglion cyst arising from the joint, or a soft tissue mass tumor compressing the nerve. So that's the kind of presentation you may see if the peroneal nerve is entrapped at the level of lateral knee. Any other questions? Or if it's just the compression, you will see the same picture where you will see with every entrapment, you will see focal nerve swelling or hourglass deformity of the nerve, and that is the presentation with all types of nerve entrapment, including carpal tunnel and cubital tunnel. You will see focal swelling or physical deformity of the nerve at the site of compression. Okay, very good. Any other questions? Good, very good. Okay, very good. Okay, thank you for being here, and I'll see you next time. Thank you. Good night.